you can tell the patient, I want you to put your fingers right here, and you have them put them across T1 or T2, and then put the bolster underneath it, and then say, I want you to feel that stretch between your fingers and the pressure on that bolster. And then, oh yeah, okay, I got it, that's good. So you can get feedback from them as to your specificity. But by having it here, you're controlling that way upper thoracic area, T1, 2, 3. So if you're here, you're going to be in line to control more the mid-thoracic area. So the only difference between the upper thoracic area manipulation like this and the mid-thoracic area, when you're setting them up, is the arm placement. So cross your arms like you're cold. Okay, good. All right, and then I can grip like this. Okay. Okay. Squeeze. Scoot back some. And then come in your head. Squeeze like that. All right, so you just change the position from here to here. And if you think about it, if you're grabbing the forearms here, your manipulation is going to be here, because your arms are coming right like that. And if you're here, your manipulation is going to be here. So your force is going to be through where you're grabbing from. That way, mid-thoracic area. This way, upper thoracic area. Okay. So think about their arm position, and that's the direction of force should be over the area where you're trying to manipulate. Okay. So that's that one. So that covers, and then we have the good old-fashioned gabbing high velocity at right 5, at right cassette C5-6. You guys already practiced that. I'm not so sure that's the go-to treatment for cervical radiculopathy. The person has herniated disc and you're doing rotation and flexion. You know, that may have been how they herniated their disc to begin with. So I wouldn't do a lot of rotational maneuvers in the thoracic or cervical spine. I do more side bending to get the nose, maybe some extension. If it's more like a degenerative changes, cassette arthrosis and stuff, then maybe the manipulation would be okay. But if there's a known disc herniation, I don't think I'd go right to that right off the bat. I don't think it's a great idea. And I think Dr. Boyce and Dr. Loneman and Dr. Gino would also agree with that. But those are techniques that are utilized. I'd say I'd be a little more cautious. Usually you can get really great results with some thoracic manips, some grade 2 through 4 manipulation, side bending mobs, gaining extension or flexion on the cervical spine, and then good home exercise program along with traction. And the evidence over and over says traction with radiculopathy, peanut butter and jelly. So that's the way to do it. Okay. And then we have the muscle